Thank you, Grant. And I know how many of you deal with AMD in this room? I mean, a few of us, but all right. Now let's talk about the new elephant in the room, which is dry AMD. Uh, can I? Yeah. So really, but practically there's no treatment for GA. And there are a lot of things in late clinical trials, but the point is that the treatment is coming, and some treatments have already been approved in the United States. And those of us who are going to be managing GA need to be prepared to manage GA. And it's going to change things for the patient, for you, for your practice. I think the time to start thinking about it is now. Geographic atrophy is a clinical diagnosis made on one simple photograph. A color photograph where you can see a pale area, you can see the choroidal vessels underneath, sharp demarcation, and it can usually starts, perifoveally and then moves and involves the fovea. So in the beginning, the visual acuity is fine, but patients complaining about not being able to read and, missing out things, but sometimes it can start under the fovea. The main thing is to differentiate it from inherited retinal disease because the treatment for both are quite different. So I think sometimes if you've got drusen, then you're more likely to be looking at GA rather than IRD. Fundus autofluorescence is suddenly becoming very important in this domain because you can mark out and map out the GA quite clearly. And it's also important in being able to look at the progression of GA, and if you're involved in a clinical trial, for sure they're going to ask you to do a fluorescein, an autofluorescence rather than a fluorescein angiography. There are different patterns of autofluorescence. It could be focal, it could be banded, there could be diffuse trickling, and the diffuse trickling one is the one that's associated with rapid progression of the GA. And in all clinical studies so far, the primary outcome is the rate of growth of the GA. So, it's all dependent on autofluorescence. So while AMD is multifactorial and there's the physiology and lifestyle and environment, I think, and there's genes, but I think what's becoming more and more important is that inflammation seems to play a role in this thing. And then complement comes into the equation. There are key lines of evidence for genetics, CFH, CFI, C3, C9. But that's not all. There are many pathways implicated in the pathophysiology of GA, and so there are as many current treatment approaches. But today we're just going to talk about the inflammation and complement inhibition. So that sort of gives you a snapshot of the pipeline, including the drugs that have failed. One that's still early in the development is to sort of suppress complement factor B. The advantage here is it can be given by subcutaneous injection. Again, it's in development. Gene therapy has the potential for a one-off treatment. Gene therapy in Australia, in Melbourne, started in 2021. And then there's also, the other early inhibition of complement. But really, what we've got in hand and what's around the corner is to do with C3 and C5, which accumulate in drusen and the sub-RP space in AMD. So I'm going to talk about the C3 and then C5 inhibition studies. The C3 inhibition is using PCP. It's a complement inhibitor, and it binds, doesn't matter what the pathway is, but it binds to the complement pathway, blocks it, and hopefully prevents cell death. The AIOC and Derby trial use PCP. Large study, 4 groups, PCP every month, every second month, and then 2 sham arms, again dependent on autofluorescence. But the main thing to remember is that the drug that you inject is quite oily and that it is a 0.1 mil injection. And again, looking at the growth rate, in the AIOC study, the primary endpoint was reached where it slowed the growth down. In the Derby study, at the end of 1 year, it wasn't reached. But when you went on to 2 years, you can see that continuous treatment helped to slow down the rate of growth of GA. And you can see that here on this autofluorescence, how you look at the reduction in growth by actually calculating. Now, GA normally grows at about 100 or 150 microns a year. And then if you can slow the growth down, you can also calculate the square millimeters of retina preserved. And so it gives you an idea how you can quantify what you're doing. The good thing is that the better result between foveal and subfoveal is in the non-foveal region, in the non-foveal patches of GA, which is good because then you can prevent the fovea from getting involved and perhaps preserve the vision. So as you combine, you look at non-subfoveal, which is on the left, and subfoveal, you can see that the effect is greater in non-subfoveal regions. They've gone to the extent of also calculating the number of RPE cells saved, but unfortunately, in terms of the visual function endpoints, they were not achieved. You wouldn't expect that if the fovea is involved, but what one could do is microperimetry in the junctional zone to see whether that makes a difference. So that's 250 microns around the lesion, and you can see that it did have a positive effect on the mean sensitivity and the number of scotomatous points when you use an investigation like microperimetry. Let's go on to the third year, the Gale study, which is the extension, and you find that the gap between the treatment and the sham arms keeps on increasing, which means the result of the drug is such that you continue to get some positive effect. After 2 years, when the sham arm was put on treatment, again, the response can be seen in that green line there. Again, AI to the rescue, you can see, we know that photoreceptors are lost before RPE, and that's shown here using AI again and the OCT, where you can see that the loss of photoreceptors is earlier and faster than that of the retinal pigment epithelium, and this drug then actually protects photoreceptor and RPE loss, as you can see here. So this might be another tool that one can use in addition to microperimetry for future studies. The adverse events over 24 months, none really significant, but as we go on, one thing that did become apparent that in this group, there was an increased prevalence of or incidence of neovascular AMD, and usually occurs at the edge of the GA and the normal tissue. It's occult and it responds quite well to treatment with our standard anti-VEGF agents, and monthly injections give you a greater chance of developing neovascular AMD in this group. So safety-wise, there didn't seem to be anything unusual, but one's got to be cognizant of the fact that AMD does develop. So the other trial that is again, perhaps even more spectacular than this is C5 inhibition using ACP. I always find it difficult to pronounce all these molecules, so we just call it ACP2. But the GATHER study shows that there's a 56% reduction in geographic atrophy at 12 months. So these two drugs are around the corner. They're available in the US, and I hope that next year or even this year, we'd have access to them in Australia. But the take-home message is really that our thinking needs to change. We can't treat dry or we can't treat GA the same way as we treat neovascular AMD. We need to prepare for treatment of GA. We need to educate the patient. We need to start thinking differently in terms of trying to preserve retinal tissue, in terms of trying to preserve or slow down visual loss. So we need to also be able to confidently diagnose GA and make sure that we don't get stuck in things that look like GA, because then that would be a disaster. So they're around the corner. It's another group of patients whom we should be able to help, but you need to start thinking about that right now.